Good morning, everyone. I hope you can hear me. We're just waiting on one participant. We've given her 1 minute to arrive, and she's our first up. So just hold on, please. So good morning, everyone. Thank you for making time to come for this panel. And our panel is titled The Next and Here Frontier, Upholding Quality of Care in Family Planning Self-Care Interventions. We have a great set of presenters that are going to take us through a couple of that are going to share their experiences in this area. Self-care is not new. But over the last decade, it has grown to become one of the more important advances of how individuals can access healthcare, including family planning. Quality of care interventions are usually, as you know, facility-based interventions. But our work calls on us to link these self-care activities and interventions into quality of care systems. So, we shall be discussing elements that strengthen interventions and develop sustainable quality of care frameworks and systems for self-care. The quality of care frameworks and approaches that have been traditionally applied may not work exactly as they work for facilities, but in self-care, we'll see tweaks and we'll see adaptations that our panelists are going to be sharing with us. We shall explore the role of quality of care interventions. We shall explore challenges in measuring, improving, and even maintaining this quality of care for self-care in family planning. So in the next hour or so, buckle up. Our panelists will describe the process for prioritizing quality of care while introducing new family planning methods, the Kaya diaphragm. We shall also discuss practical approaches to addressing common quality of care deficits in self-care interventions in FP. We shall look at the application of a self-care framework for an FP program with DMPA, subcutaneous rings, and other client-controlled methods at the national level. And lastly, we shall also describe challenges specific to quality of care, self-care interventions in humanitarian settings. With that, I'd like to introduce our first speaker and call upon, let's have the presentation for Dr. Lillian. Dr. Lillian is a clinical doctor. She is the deputy country representative at PSI Uganda. She's a clinical doctor with a master's in public health, and she has over 10 years of strategic leadership experience with specific expertise in sexual reproductive health. And she has been involved as a member of Uganda's self-care expert group, where she has been instrumental in facilitating the uptake and integration into the government of Uganda's self-care quality of care framework. Dr. Lillian, you're welcome.
Thank you very much, Dr. Millie. Am I stand there? Okay. I think for a better presentation, I reckon I should stand there. Thank you very much, Dr. Millie, for that good presentation. I am, once again, Dr. Nancy Kabembe. I work for PSI Uganda and as a member of the self-care expert group. So this morning, or this early afternoon, I am speaking to how we are required to maintain health sector accountability while adapting a self-care quality of care framework for family planning in Uganda. We will be able to look at the background of our work. We'll look at a methodology that involves our test implementation on the adaptation process. We'll look at the results and what next as a conclusion. prior to delving into that detail, allow me to acknowledge the people with whom we are advancing this agenda in the country. I recognize our Minister of Health that is chairing a self-care expert group that will speak about for everybody's information. Allow me to recognize our National Self-Care Consultant, who's a local medical doctor in the country, and also PSI as a secretariat of the work that we have been doing. I'll start off by recognizing the work that the World Health Organization has shared with us. We realized that for us to, in a structured manner, to advance our work, it was after the WHO had released the consolidated self-care guideline for health in 2019, and that spurred us into a movement and action to advance the self-care agenda in the country. I'll also recognize the Self-Care Trailblazer Group that many of us have heard of, and I reckon are part of, because it's a global coalition that brings together several partners with the agenda of advancing self-care in a very structured manner. We also recognize that the Self-Care Trailblazer Group is responsible for producing multiple frameworks that guide our work in the different countries. And specifically, I'll mention, for the sake of our conversation today, the self-care, quality of care framework that is directing our work at the country at the moment. But we also know that they've also done work around the SBC tools, that there's a big toolkit about SBC and advocacy as well. Then, boldly, I'll recognize the self-care expert group in the country, which is a group of, I want to say, technical and well-skilled people who are leading the advancement of self-care in the country. And so I recognize it is chaired by the Minister of Health, and it has implementing partners, including PSI, as well as CHAD. Some of us have heard about them. They lead the rights framework in the country, rights for health in the country, and the advocacy partner in country for Self-Care Trailblazer Group. Then there is also partners like PATH, who are doing a lot of work under DMPSC. There's FHI 360, there's JPEGO, who are all members of this group, and they're in a structured manner leading this advancement. Then there is also academia, which is the School of Public Health, that is also leading our measurement piece in country. I think that would be good background before we delve into the work that we have been doing. So as a background, we want to recognize the fact that as government, even with bringing self-care in a structured manner, they recognize that it's integral and complementary to the health system. And as such, it has a role to play in ensuring that we achieve our health outcomes as a country. In addition, they recognize that it's a strategy for advancing the universal health coverage and not necessarily a shortcut. So they retain their responsibility of ensuring that the citizens have a good healthcare or quality healthcare services. And then they also realize that, and together with the partners, realize that it's a strategy of reducing the workload of the already burdened healthcare system. And it's not necessarily taking away their responsibility as the country. And as such, to it and to its partners, it is a priority that citizens receive high quality, monitored and supported services, while ensuring that the individual remains empowered to safely manage their own care. Also, we have learned through COVID, which has been a turmoil across countries or globally, that while government is ensuring that individuals have access and there is good demand for services, they must remain cognizant that as individuals we have preferences for family planning, and that should be taken into account. Like I previously mentioned, that the WHO guidelines spurred us into motion to advance the self-care movement in the country, and as such, it is for us to be able to adapt the quality of care framework nationally. We require information, evidence to be able to adapt the global good into the country context. And as such, the Ministry of Health, through a self-care expert group, is leading and enabling the learning of the acceptability, the feasibility, and applicability of this particular guideline or framework into the national system. So I'll walk you through our methodology. It has been rather qualitative for everybody's information, and we're using this information to be able to answer this particular question that we had. And so the purpose for testing this guideline within the context was to evaluate the quality of care framework's interaction with the existing mixed health system. And we're looking at both public and the private sectors and the community as well. And we recognize that we are structuring our work within the principles of quality of care. For the purpose of this work, we are looking at enabling environment and accountability, while for the global quality of care framework for self-care, it also has other elements. It also has other principles of places of access that we should have at the back of our minds. Then also our evaluation is focused again around health systems accountability and regulated products and interventions as a critical elements. But again, we're aware of the fact that there are other elements which include healthcare, the healthcarers themselves. There are other elements also include the trained health workforce as the other elements of critical for family planning, quality of care, self-care. Again, we recognize that under quality of care, there are 5 domains that include technical competence, client safety, information exchange, interconnectedness, and continuity of care. And for the purpose of our evaluation, looking at responsibility of government, we are focusing on only on all the 5 domains, but only 10 standards. So I earlier mentioned or referred to the fact that the self-expert group is advancing the agenda of self-care in the country. And as such, we took time to begin the process of adapting the global WHO framework to a guideline into a context. So again, before we could finalize our draft, we made a determination as a country, that is Ministry of Health and its partners, to test and confirm that this can be applied within a local setting. So we are taking advantage of that environment to again test this quality of care framework and utilizing the same base to test this particular framework. So that's why I'm saying that it is our work is nested within the testing of the National Self-Care Guideline in one district that we had to select based on various parameters across the mixed health system, and is again coordinated by the self-care expert group. Before we could go out, we had to understand what do we actually want to learn when it comes to quality of care adaptation within the system. So we set up learning questions across the 5 domains, and that relate to accountability and an enabling environment when it comes to government. And so our learning questions focused for us, if I could speak to about technical competence, we're asking ourselves that, do the healthcare providers have the skill to transfer family planning self-care to an individual to be able to care for themselves? That's one of the questions, one of the questions we had about technical competence. Again, we're asking ourselves, within that district level, do they have the ability, do they have a system that is able to monitor the work that happens when it comes to self-care interventions within the district system? Another learning question we had about client safety was about, do we have a regulated or an approved WHO product within the structures? And in this case, we're looking at Cyanopress, which is WHO approved. When it came to information exchange, we wanted to understand, is there practical mechanism that allows clients to provide feedback to the health workers on how they are performing? When it came to interpersonal connectedness and choice, we're asking ourselves, is there a mechanism in place that allows clients to receive feedback when it comes to what to give feedback on the challenges and successes as they implement the work? Then when it comes to continuum of care, is there a mechanism that allows for referral and even other options that are not available at that particular health facility or even in the community? So that's what our learning questions were focused on. Like I previously mentioned, they're primarily qualitative. So before we went into the field, we've done a lot of preparation, and that has taken us a while. It took us about 12 months because it required putting together resources, a big thing. It required human resource, but also the financial resources to be able to test this. And so the preparation, we did preparation at the national level, but also at the district level. So in the preparation at national level, it involved defining the learning questions, understanding what exactly, how we're going to measure them, what will be the data sources when we go down the district. It involved training, identifying national trainers who spread beyond the health system, because we recognize that self-care is not all about the health. It's not all about the health, but it also spans into other entities, including the local government, including political leaders, because we're looking at how accessible can it be within the health system, but also within the district of local governance. And then at a subnational level, which in this case is a district, we were able to identify, we worked with them and identified health facilities for us to work with, and also the community members to work with. We were able to identify about 10 public facilities and then 8 private facilities that include pharmacies and drug shops as well. And then also we were looking at least some community health workers that are attached to particular health facilities. At the district, also oriented the district stakeholders that, like I said, spanned beyond the health system. And also we did, under implementation, then we went ahead to train the providers mentioned. We also went ahead to conduct the orientation, but also did a lot of SBS activity to radio talk shows specifically to be able to inform the communities of what was going on. Then I've already alluded to what we've done under monitoring and evaluation, determine the learning questions and also the potential data sources. And in this case, we were looking at we did key format interviews or interviews with the self-carers. We also did interviews in a small sample size, of course, and then also we did health providers, district leadership, and also some members of the community. At the facility, we went and checked out health facility data. We're looking at stock records, even health information systems. We're looking at the health facility records, outpatient records as well. This is just to show you our process, how far we've come in developing the national guideline, as well as testing the self-care quality of care framework within the existing health system. We started the journey in 2019 once WHO released the guidelines, and then through March 2020, when COVID hit the country, we went into a virtual mode of starting the stakeholder integration, and then also the process of developing the guideline. So we're at a point where we have received some feedback, and we are in the process of finalizing and preparing the guideline for approval. Like I mentioned earlier, the quality of care framework is part of the guideline. So I have some general findings and observations to share with you, and I will, because we're testing it with the healthcare system, we were checking to see how prepared the system is to receive, to support or facilitate self-care when it comes to family planning. And we recognize that there are overt differences between the public and the private sector, because we know that majority of population seeks care and also family planning from the public sector. But we also, and knowing that Uganda has a general population that over 80% live in the rural area. So, and when we're looking at health system providers, looking at issues of, do they have stock in place, do they have records management in place to be able to support and report on the self-care interventions. And again, we found, I'll talk about data management reporting, we found that there was better work done. There was some work that had been done in the public sector, where providers were improvising a section within the existing HMIS system, and to where they could report vials given out to the self-care provider, carer, to take home with them. While in the private sector, it was rather limited. When it came to accessibility among health providers, we found that the public sector looked at it in such a way that it was relieving the workload that they had, while in the private sector looking at it in the angle of what does it mean for a number of clients that we see coming into the facility on a regular basis, and that's our income being affected. When it came to continuity of care, we'll learn that, again, there were different mechanisms established, put in place in the public sector, though they remained rather weak, and such an implication for us to be able to enhance or strengthen that mechanism. When it came to uptake of family planning, it was established that SI, self-injection, was well interpreted as a form of self-care compared to the oral contraceptive pill, even in the emergency contraceptive pill. So there was a strong focus on self-injection in the results that we have here. And now, specific to the family planning self-care quality of care framework, we found within the domain that I mentioned, and also mentioned about the different standards within the 5 domains. Competence, work has been done, and we found that, and we know through the work that has been done, including also PSI work and PATH work, where because clients or self-carers were afraid to self-inject. We are used to a provider giving us, taking care of us, and doing the injection for us. Government of Uganda, together with partners, including, like I mentioned, PATH and PSI, we have designed a self-injection empathy module that allows the provider to be more empathetic, or facilitate provider to be more empathetic while advising the client on how to self-inject and care for themselves. And also included information on when to return when they have issues and need support on when they're having complications and how to best manage them.
Lilian, you have 1 minute.
1 minute, okay. We also confirmed the technical competence that the government, the district has a support supervision system for DMPSC, with the self-injection, but with limited documentation on what actions are taken once they've found gaps at the different levels. Then client safety, we confirmed that the cyana is available in at the different facilities, and we saw no expiration of any product because there's limited stock generally in the country. And as you will note that the guidelines exist at district and public facilities, but only 60% of providers had guidelines about how to utilize DMPSC. Information exchange, as we can see that clients are counseled generally on all options in the public sector compared to the public sector. And just to close it up, when it comes to interpersonal connection and choice, where we are allowing the client to report on whether the system was empathetic to them, was respectful, we found no specific mechanism at both public and private facilities, and such an indication to government that we need to provide special support to both the public and the private sector. And continuity of care, despite finding a structured referral system, it's limited, and as such should be scaled up as we do the scale up across the country. And in conclusion, we're asking ourselves, what are the next steps? And primarily, we're saying that we should be able to finalize the guideline and be able to have it approved and thus scaled up across the country in a phased approach as we look at the resources available in the country. And again, learning from the issues that are coming back to us, realize that we need to pay special attention to special populations, and these include in humanitarian setting. We know that we've had that pandemic coming up to us, and how best is the system prepared to be able to support that, and also the young people. So thank you very much.
Thank you, Lydia. Our next presenter is Dr. Blamy. We are really privileged to have him on this panel. He will be discussing quality of care through counseling in DMPA-SA self-inject, and he'll be talking about a multi-country study done in Francophone Africa. He is the technical director for Western and Central Africa, JAPIGO. He is a professor of obstetrics and gynecology from Burkina Faso, and he has had experience that includes maternal, reproductive health, family planning, and cervical cancer. Dr. Blamy, the floor is yours.
Good morning, everyone. Thank you, Madam Chair, for giving me this opportunity to share with this audience the result of a multi-country study in Francophone Africa on the quality of counseling for DMPA-SC self-injection. I am presenting on behalf of my co-author. Some of them are present in this room. Providing subcutaneous DMPA-SC, like any other method, require good exchange between the provider and the client, sound information, as that can lead to a safe and quality choice, increase the uptake of a method and its continuation. The former presenter has already mentioned the 5 domains of the quality of care framework for self-care, And we think that good counseling can address those 5 domains. Our experience with the introduction of DMPR SC and its scale-up in Francophone Africa offer lessons regarding the quality of counseling. I must mention that this study has been done under the regional DMPR SC project implemented by JPIGO in 8 countries in Francophone Africa with the support of the Bill and Melinda Gates Foundation. 2 main objectives of the study. The first one was to assess the quality of the counseling, then to identify area of improvement for that counseling, because we know that counseling is the entry point for any family planning method. The study was conducted in 4 countries, Burkina Faso, Guinea, Mali, and Togo. And each of these countries, family planning providers were trained and supervised on counseling and provision of DMPR-SC, including self-injection. For the counseling part of the training, we used a standardized set of material, which include a booklet explaining the step of the self-injection of DMPR-SC, a calendar for timing of self-injection, a video animation translated into local language in those 4 countries, a simulation model made of a condom filled with salt, a vial of DMPR-SC, so the provider is able to show to the client how to do it, then checklist to follow the different steps that need to be in place for the self-injection. The study took place in 40 facilities, 10 in each country, 5 in a rural area, and 5 in urban area. We made sure that rural areas are included, because in those 4 countries, most of the women live in those areas. An interview was conducted by trained healthcare workers using a standardized questionnaire, which has, apart from the demographic characteristics of the client, 9 items on it. We collect data using tablet through the Kobo Collect tool platform, and those data were analyzing using Excel and SPSS. Of course, ethical clearance was obtained from the local IRB in those 4 countries, and also from the Johns Hopkins University School of Public Health, Institutional Review Board. What were the results? Regarding the demographic characteristic of a client, we have included in this study 384 clients per country, giving a total of 1,536 clients, and also 30 providers from the 4 countries. The majority of the clients were younger than 30 years in both urban and rural settings, except Togo, where they were older. They were all married in most of the cases, and the literacy level was at most the primary school level, except in Guinea and Togo, where in urban setting, most of women have attended secondary school. The clients in this study were, in a majority of cases, housewives and self-employed. Those characteristics, in fact, are similar to women characteristics in general population in Francophone Africa. When we ask women what are the main reasons for using self-injection, 2 reasons emerge. The first one is the discretion of the method. You can do it in your room, in your workplace, nobody will see you. The second reason was what they consider to be the long duration of the method. You see, 3 months. I guess they were comparing DMPRC to the pill that you have to take on a daily basis. Regarding the main question, we see the quality of counseling. I said 9 questions were asked to those women, those clients. Out of those 9 questions, 5 were satisfactory. The first one is about having the possibility to ask questions to the provider, because sometimes clients are afraid to ask questions. They said in most of the cases, they were able to ask questions. And those questions were answered by the provider. They have information about the availability of other methods of family planning. I think that is an important issue because we are not introducing the MPR-SA to replace the other method. We want to expand the choice of the client. The fourth item that was satisfactory in terms of counseling is about information about the possible side effect. We know side effect is one of the main reasons for discontinuation of method. And the last item that was satisfactory is the confidentiality of information that the client has received. However, there are areas that need to be improved. The first one, women say they didn't hear about the possibility to switch to another method if they were not satisfied with the MPR-SA. The second one is providing information about side effects regardless of the setting, because we have noticed that clients in rural areas said they have not received enough information about the side effect, and also explaining how to manage the side effect. I already mentioned that side effect is one of the main reasons for discontinuation of family planning method. And finally, visual privacy. 70% of clients in rural areas said they could be seen by other clients during the counseling session. We also asked providers how they were satisfied with the counseling materials they have received. Across all 4 countries, between 90 and 100% of providers said the material was good and suitable for the counseling for DMPR-SA self-injection. Based on these results, we can say that in the 4 countries, clients in general and providers are satisfied with the counseling they have received or the materials they are using for the counseling. We have identified 4 areas of improvement. It is important to address those areas if we want to continue to have more and more clients choosing the MPR-SA self-injection and continuing to use them. I would like to end by thanking all the clients who participate in the study, as well as the provider, the Minister of Health in the 4 countries, which allow us to use their facilities, and finally, the donor who provide both technical and financial assistance. Thank you very much.
Thank you. Thank you, Dr. Blamy. We shall have an opportunity for question and answer, so please do take down notes at the end of this session. Our next presenter is going to tell us about introduction with a specific method and the quality of counseling of self-care. This is Alexandra Angel. She is the technical advisor with Population Services International, and she has worked a lot in the area of quality of care, person-centered care in approaches and the support of uptake of family planning as well. She has also had experience in the introduction of new contraceptive technologies and integrating these into existing markets. So she will be telling us about Kaya. Alexandra, you're welcome.
Thanks, Millie. Thanks, Dr. Millie. So I'll be sharing with you about supporting Kaya diaphragm users and specifically thinking about how we thought about quality of care for this self-care method. This work was conducted by a consortium of partners, including Catalyst Global, Population Services International, and the Beninese Association for Social Marketing, or ABMS. Okay, show of hands. Without this slide, who could tell me a fact about the Kaya diaphragm? Okay, great. Not that many of you, so it's good that I have this slide. Many of us are familiar with diaphragms, right? They've been around a long time. But the Kaya contour diaphragm is a little bit different. It innovates upon these older methods, these older versions of diaphragms. And one of the most interesting things about it is that it comes in a single size. Prior versions, other versions of diaphragms come in multiple sizes for which you have to visit a provider and be fitted at the clinic. The Kaya diaphragm eliminates this need, and so eliminates the need to visit your provider to find the right size. It's reportedly easier to use than traditional diaphragms, and it's reusable. A client could use this for up to 2 years, though it is indicated for use with a gel to facilitate insertion, which does have to be restocked or reobtained. It's a modern method, it's on demand, it's a self-care option, and it's effective. With typical use, it's about the equivalent effectiveness as a male condom. Although it is available in some countries, it's not very widely available in sub-Saharan Africa. So through the USAID-funded Expanding Effective Contraceptive Options Project, or ECO, we introduced this method through pilot introductions into 2 countries, into Niamey, Niger, and into 2 urban centers in Benin. And just to give you guys a picture of what these contexts are like, they're places where the MCPR is still quite low, 19% among all women in Niamey and 13% among all women in Benin. And they're also places where the method mix is dominated or skewed towards one or a couple of methods, OCPs in Niger, and implants and condoms in Benin. Through this pilot introduction, ECO, which took place over 2019 through 2022, ECO worked across a number of different sectors and with a number of different healthcare workers. In both Niger and in Benin, we worked in the private sector, where the method could be purchased at a facility after visiting a provider for a subsidized price, though it was sometimes also given freely during free distribution campaigns. In Niger, we also worked with the public sector, where clients could visit a public sector facility and obtain the method for free. In Niger as well, we worked with 5 community health workers who were equipped to sell the method directly to clients in the community without them having to go in to visit a facility. And then in Benin, we were able to leverage a couple of other avenues for potential users to access information through Facebook and through a phone hotline. And as I continue to go through this presentation, as you can see, we worked with a number of different providers. I'll be using the term providers as a general term moving forward and thinking about these different healthcare workers in these different sectors. All right, so that's sort of the model for this pilot introduction. Where did quality come in? How were we thinking about quality for this work? The previous 2 speakers spoke about the different domains of quality, so I won't get too much into that, except again to reference that they come from they pull from the Bruce Jane framework for quality. We thought a lot about trainings, job aids, standardized communication materials. The providers who began offering Kaya were already FP providers or had a background in family planning. And so the 3 to 4 day trainings they received did include modules that focused on a review of informed choice and a review of contraceptive technology, but really the focus was giving them information on Kaya specifically, the details of Kaya, how to counsel around it, what information the client might be needing. And there were also lots of opportunities for practical practice of counseling sessions during these trainings. They were also providers were also equipped with different job aids. It included samples of Kaya to use during counseling sessions. It included a flip chart, which reviewed the instructions for insertion and removal of the diaphragm. And it also, very importantly, included a pelvic model that providers could use to both demonstrate for clients and to allow clients to practice insertion and removal on the model themselves. As part of the work that was this digital piece in Benin or other mass communication activities, we also developed some standardized video and some communication to help standardize the messages that were being shared. There are the 5 different domains that the other presenters have shared. We were thinking particularly about 2 of them, information exchange and interpersonal communication and choice. For a self-care method like Kaya, where the effectiveness really depends upon the client's understanding the method from the beginning to use it effectively and for it to be most effective, these 2 domains are very important. Providers who were newly trained in Kaya provision were then integrated into existing supportive supervision systems, quality of care systems that were already operating within our programs, our PSI and ABMS programs in Niger and Benin. Okay, from here, what did we learn? I'm going to use a couple of information sources as we go through this, as I go through what we've learned. And it really is a synthesis of information that comes from a number of places. It comes from program experience, monitoring data, and then it does come from some human subject research as well. The goals and aims of all of these different data sources are a little bit different. So what I am doing is synthesizing the pieces that are around quality of care. In terms of program data, we're looking at some mystery client surveys that were conducted in both Niger and Benin, and also looking at some routine data, monitoring data from the digital pieces and hotline pieces from Benin. And then in terms of human subject research, there were 2 mixed method studies conducted, one in Niger, one in Benin. And as a part of these studies, we conducted in-depth interviews with adopters of Kaya, with Kaya providers, and with men who had been sensitized to the method. And then we also conducted surveys, follow-up surveys with adopters 6 months after they had selected and adopted the method. All right, I'll start with information from our mystery client surveys. In Niger, this was conducted at just one point in time, and it came just 4 months after training, so relatively early in the activities. In Benin, we were able to do it twice, once 9 months after the initial training with providers, and once at 21 months. And the aims of these surveys or these studies was really to identify some quality gaps so that we as an activity, as a project, could be aware of them and then work to improve them over the course of programming. There's a few summary findings that are here, and I'll just go over them quickly. We found that clients were not always able to practice insertion with the pelvic models. And we saw that in both Niger and in Benin. In Niger, as I mentioned, this survey came at the beginning of the activities, and so we know that there weren't always actually the models there for them yet, and that was something that we were able to fix. In Benin, providers would have had models, but they weren't always using them, and so that was a really important piece of information for us to learn. At most visits, providers were introducing Kaya spontaneously as part of the counseling session. So the mystery client wasn't having to do any prompting. The provider was able to integrate the information and this new method into their existing offering. That being said, there was some bias noted among some providers related to this method and who it might be the best method for. The most used counseling tool in Benin was the printed job aid, and that's what's in this photo up here. And it includes information, this job aid includes information on the instructions for how to insert and remove the diaphragm and how to store it. A couple of other pieces of information that the client would need to know if she had already expressed interest in this particular method. And then we looked at a number of different steps or standards for counseling as part of these surveys. Providers tended to score higher on the counseling steps that come before a client makes the method choice, so things like respecting the client, inviting her and welcoming her into the clinic, and tended to score a little bit lower on the information that was new to providers around Kaya specifically, how to use it, and the different attributes of the method. I mentioned that in Benin, we conducted this study twice, and so it allowed us to compare a little bit over time how providers were doing. What you see here are different steps in the checklist that would have been used for counseling for this method, and these are some of the Kaya-specific steps that I've pulled out. As you can see, there's some improvement over time, and then there's some places where there's not improvement over time, and where scores are not improving between the two surveys. If you look at what these steps are, the ones where there's some improvement tend to be around the sort of instructions on how to insert and how to remove the diaphragm. This is the information that was in the job aid that we know that providers were really relying on in Benin. The steps where we saw some decrease in scores tended to be things that were more about the qualities of kaya, the benefits of kaya, some of the information that wasn't in that job aid, and that the client might want to know before she's chosen the method, if it would be a method that might be right for her. This information here next is a little bit of program experience around the digital and phone line pieces of the activity in Benin. So ABMS in Benin already operates a Facebook page for young people that focuses on love, relationships, and contraceptives. And they also already operate a phone line where women, men can call in and ask some basic information around family planning. ICFP was able to use these couple of activities to share some information around kaya. And in one period, 6-month period of programming, ABMS published 8 informational posts around kaya to this Facebook page. And we saw that more than 5,000 people were viewing the posts and responding with the posts, sometimes commenting directly and asking questions, seeking more information about kaya or where to get it. These Facebook posts would also share information around this phone hotline that people could call into. And during this period where the posts were in Facebook, 288 people called the hotline specifically asking questions around kaya. And again, asking basic informations about the method. Is it hormonal? Does it cause side effects? And then also where they could obtain this method. Okay, turning to sort of our last data source. This comes from our human subjects research that took place in Niger and in Benin. And I've synthesized and pulled a little bit of information that would be related to quality that comes from these studies. Around continued use and satisfaction is what you see as the percentages up here. So in Niger and in Benin, many people who adopted kaya were continuing to use it at 6 months when we followed up with them, 76%. And many of these users were satisfied with the method as well. We only were able to ask this question in Benin, but in Benin, 87% of those people that had adopted and were using the method were satisfied with it and had positive experience with their use of kaya. If we look at sort of the other set of adopters, those that discontinued, there are a number of reasons why different users in the two countries stated that they decided to stop using the method. I think in particular of interest here is in Benin, and we don't see this in Niger. The top reason for stating that they had discontinued the method was that users felt incapable of proper insertion, incapable or uncomfortable with proper insertion. If you think back to some of the other information we looked at, Benin was where clients didn't necessarily have as much opportunity to practice insertion when seeking out the method.
2 minutes left.
Thanks. There was also a qualitative piece to this study, so a few things I'll pull out here. In terms of choice and satisfaction, kaya was seen by both users, adopters, and providers as a new option that didn't have a comparable equivalent already in the market. When we asked adopters why they had selected kaya, they often shared some of these same 3 things: that it was an on-demand method, that it had no side effects, that it was user-controlled. That's all correct information about the kaya diaphragm, and could indicate that clients really did have the information they needed after the time of counseling to choose this method, knowing that it would be something they were interested in and would work for them. I'll mention the pelvic models again. In Niger, providers did say that the pelvic model was imperative and very important for them. They felt like that was the tool that they had that enabled them to ensure that clients that they were working with felt comfortable with the kaya diaphragm, the insertion, the removal before they took it home and used it themselves. And then a little bit about information exchange and interpersonal communication. In Niger, we saw that that adopters expressed a preference for working and asking questions of the community health workers. That they felt particularly comfortable going to these health workers when they had discrete questions, things that they felt private or maybe embarrassed to ask. And so these were really key pieces of the Kaya distribution approach in Niger. That being said, many users still chose to access the method, to purchase it or get it for free in Niger through a facility, a provider at a facility. All right, so that was a lot. There was lots of different information. I feel like it went really fast. Maybe you felt like it went really fast. And so I'll share a couple of conclusions to try and tie this all together. The first, that traditional service delivery providers are important actors in self-care. Even though Kaya is a method that could be accessed through something like a pharmacy, in some countries maybe something you could even get online, in some places, in all places, the traditional service delivery providers, and certainly in the work that we did, were incredibly important. It's where our users were able to actually access the method itself after perhaps getting information about it from a different source. New digital channels or lower cadre healthcare workers are uniquely suited to self-care information, counseling, and product provision. We saw in Niger and in Benin, in different ways, that users really valued the opportunity to seek information and support about this method from outside of a traditional facility-based setting. In Niger, that was through community health workers. In Benin, that was through seeking information from a phone line or from Facebook. And then regardless of method distribution approach, supporting clients with quality information and counseling is critical, right? For a method like Kaya, for any self-care method, where the effectiveness of the method depends on the client getting accurate information first, and then going home and being able to control the method herself, quality information exchange and counseling is highly, highly important. And that's it. Thank you so much for your attention. And then thank you on behalf also of like the many colleagues that put this work together in Niger and Benin across the world.
Thank you, Alexandra. Our last speaker is going to speak about strengthening client choice and continuity of care in and advancing quality of care for self-care interventions in humanitarian settings. Dr. Cyprian is from Kinshasa University. He has 7 years experience working with women and children. And as you can see, he's from IRC. He's currently deployed in Bangui, Central African Republic as a health and nutrition coordinator. Unfortunately, we were not able to get translation for this session. It is in English, so please read along. He's going to give it in French. If there's any different, anything different in the slides or any point that he wants to emphasize, we have someone who will pull out that in the discussion. Dr. Cyprian.
Thank you, Dr. Millie. Good afternoon, everyone. I ask apologies to present in French for better comment, but the text is in English. You can link what I am saying and what he is writing. Je vais vous présenter un peu
I will make a presentation on what we have, on the factors that we have observed that influence the quality in self-care interventions in humanitarian settings, and particularly in humanitarian settings. That's an experience that was carried out by the IRC, the International Rescue Committee, which is an organization that works in the humanitarian field and development as well, and in many countries throughout the world, roughly 40 countries. We work in different fields such as safety, education, health, economic well-being, and good governance. We have global priorities in the field of research and innovation. So mainly increase contraceptive options through client-centered self-care models. Also, we want to reduce harm from unsafe abortion through self-management of abortion. We believe that with the lessons that we will draw from those experiences, we will be able to mobilize policymakers to bring about change and to adapt such policies in the national context so as to transform health systems that must adapt to the humanitarian context that very often are made vulnerable. So we will now introduce two programs. One of them is already over and it was conducted in DRC and based was this self-managed abortion care. And in the first model, there was a support facility-based safe abortion care in line with the Maputo Protocol. As you know, in some countries, there are some restrictions in the legal framework as to what, as to the indications of abortion. But with the arrival of the Maputo Protocol, indications on abortion have been enlarged, and it enabled healthcare providers to to help women who do not meet legal criteria to have an abortion, and they are shown how they can they can take misoprostol on their own and to monitor how the abortion evolves and then go back if there are complications. That's the first part of the program, and then there was a partnership between the IRC and private pharmacists. As you know, in a humanitarian context, the population reaches health centers very late, and it starts with private pharmacists. We've made a partnership with some pharmacists, and we have helped to build their capacity to provide counsel to all these women, and also they can prescribe misoprostol so that women can carry out the abortion on their own at home and come back if they observe any sign of complications. And with these programs, from January 2019 until November 2020, we were able to register lots of a very high turnout, about 4,395 women and adolescent girls received those care, and most of them, 68.5%, chose to purchase abortion medication at an IRC-supported pharmacy. We'll see later on what are the different elements that we had to ensure for quality. Here is the study for on the feasibility and acceptability of DMPA-SC, as the colleagues have been presented. The study was carried out in South Sudan, which is a country where there is a humanitarian situation. We started by a design phase. We are now at the implementation phase, and on the basis of interviews and focus groups, we were able to recruit participants for the study, and they were trained in how to inject um, the DMPA themselves, and also how to remember the date so that they can self-administer a a booster every 3 months. So the study aims to show how we can help build capacity of women in this self-injection of the MPA strategy. So they are uh, trained on how to remember the dates for the booster every 3 months, and how to store securely and discreetly these products, because if they are not well stored, they may lose their efficacy. And they have to store it discreetly, because some women have started a process without involving their husbands, and if the husband find the the medicine on the table, it may be an issue. So we encounter that situation, and we have helped those women to use the MPA with confidence and accuracy, and also we've trained them to dispose of the MPA safely and discreetly, because it has to be done safely. Otherwise, it can um, touch somebody else, and again, it has to be discreet, because the husband may may not agree, so it could be an issue. So on the quality aspect, as was presented in the framework at the beginning by my colleague, we have seen both programs that the technical skills play a major role, and we took that into consideration in both programs. For example, for the self-managed abortion in the DRC, we were able to train um, healthcare service providers, pharmacists on the risks of unsafe abortion and on the legal framework. And also, we have shown them what they can do, what the leeway they have with the Maputo Protocol. So we have shown them that women can self-administer the misoprostol, and results can be very good, and also how they can use the misoprostol, um, in what doses, and also the secondary the side effects, so that the woman is uh, not too uh, disturbed, and also uh, the fact that that women can go back to a pharmacy if they need. So we've trained all these participants in the study to self-administer the drug, but we were able to continue the study to make sure that the service providers and the women had really uh, learned properly how to use it. And we did it on the basis of a checklist, and in South Sudan as well. A checklist was drawn up, and we developed some um, teaching materials so that we can help these women remember the procedure, uh, and while complying with quality standards. But in South Sudan, for example, we realized that after the first injection, some women lose uh, the newly acquired skill. For example, some people do not remember, and they may expect our um, staff to go and help them. And we realize that some women do not acquire in a more spontaneous fashion these skills. But we have seen that for some women, because we are we would write the date on the medicine, but they had other methods to remember the date of the next injection. For example, the day of the market. So that's how she would remember. So she would start counting. So she knows that it's been 3 months, for example. So I have to take the booster, second booster, and so that's one of the elements that was observed as part of our program. So as for safety, we focused on the counseling that we would provide to these women so that they can be safe and protected, especially when it comes to side effects and when they should um, come back and when there are signs of side effects. And for those who use the DMPA, they were given the boxes to dispose of the medicine. But there is a very important confidentiality aspect that really has to be underscored, because once the confidentiality is broken, it really can put the women in the at risk of violence if the husbands were to find out. They may try to harm the women. Third, information exchange. Of course, we took into account the fact that we had established a network, community support networks to support these clients in order to provide them with information, but also to follow them as it should be as part of the self management abortion. We've used community program from a through word of mouth, and women would gather to inject together, and it was a way for them to remember. So that was also um, noted. As for the feedback that was strengthened, we were also able to conduct clarification values clarification exercises in order to change social standards that sometimes may engender discrimination. But in South Sudan, the reforms that were conducted by the community and by married women, which means that if something has to be done in the future, we will wonder how we can involve adolescents, for example. And as for the care, we realize that even if women were not um, in the structure, we've established some linkages, and the pharmacists who were trained were able to report the information of these women, and these pharmacists were counseling these women on top of the self-management of the abortion, and the women were encouraged to take a contraceptive method after the abortion. So we have been able to increase the level of the number of women who took a contraceptive after the abortion. Whereas in South Sudan, it was mainly a mobile population, and we were wondering how the follow-up would be carried out. We would have to think how we can have all the information. By way of conclusion, we believe that it is possible to have high quality self-care in humanitarian settings. the fundamentals of quality of care do not differ in humanitarian settings, and therefore they must be taken into account in the um, emergency preparedness. But also, these elements must be adapted to each context, and that's what was done as part of these two programs. Thank you very much. Thank you, Dr. Cyprian.
And you can direct the question to the presenter or even just to the panelists. A mic will be passed around.
Thank you all for your wonderful presentations. My name is Christine Laswai from Momentum Project. My question is to Alexandra Angel. Very interesting, Kaya diaphragm. I'd like to hear more about your data that you have on the market gap that the Kaya is feeling from a consumer perspective, particularly on who are these people who are choosing to use Kaya, preferring to use Kaya, not from a social demographic profile, but more on, other preferences. For instance, the demand or the preference for user-controlled methods, is it associated, for instance, with high contraceptive self-efficacy and low position to use? Or preferences to use on demand, is it because of these are people who are having infrequent sex? I'm just wondering if you have any information on that. Thank you.
Yeah, yes, can you hear me? Okay. Thank you for that question. And I will make a little bit of a plug for another presentation on Thursday, where I'm sharing more from the human subject research studies we did in Niger and Benin, and some of that information will be there. But since you ask now, yes, we have a little bit of that information from Benin, particularly. Kaya, as you've all just learned, is a non-hormonal option that is not linked with specific side effects. And so this is really attractive to users who might shy away from hormonal methods, from other modern methods that might be linked with other side effects. And so this has really been a key market that has been interested in Benin in this particular method. You mentioned women who have infrequent sex. We've also seen that too in both Niger and Benin, that a number of users, when sharing why they chose Kaya, shared that they chose it because other methods they had to think about more often. They had to use even when they weren't expecting to have sex for months at a time, for travel, for work, for whatever reason. So yes, this population as well. In Benin, we also found that a number of users were pairing Kaya with fertility awareness methods. And so we're using Kaya during the days that they determined they were fertile using FAM. So that is also a key group that was interested in this method.
Thank you. Any other question? I have a question for Dr. Cyprian. You mentioned, and maybe someone have to translate, you mentioned that in the DPMA setting in South Sudan, women didn't always get to competence after 3 months. These are highly mobile societies, no telephone. In your experience, is there any success intervention to address that? Or what are your thoughts around that?
Merci.
Thank you, Dr. Millie. Well, those are indeed questions that we should ask ourselves, because that's a quality element, acquiring skills and maintaining a certain level of skills. I believe that we should look into it because those are women that we have difficulty to reach. So I would suggest looking into the training methodology of these women and maybe we should train them for a longer period of time because not everyone learns in that amount of time. So I could also suggest following them after the training before they self-administer the medication. So they would maybe we could uh, meet on the day of the injection to support them so that when they are really um, prepared, they can continue on their own. And also for women, maybe we should see that self-injection strategy and see if the women have some skills because of their profession. They may already have some skills, and for example, um, women who are used to sewing, for example, um, and knitting, they may have certain skills for self-injection. So those are questions that we can ask ourselves to see if we can improve that quality element.
You're welcome to translate.
I'll just try and summarize. Sorry, I tried to take notes. um, Dr. Cyprian mentioned, ideally there would be a regular way to follow up with these clients, but oftentimes because of this population, that's not always possible. He mentioned looking at the trainings that are being provided to providers and thinking about perhaps redesign or what might be missing if this is an issue that's coming up across a number of women. Also, a potential solution is to find a day to meet with women on the day that they're first doing an injection, the first time on their own, to see how it's going and help correct and improve their understanding. And I think that was, I hope, was there anything else?
It seems that Dr. Cyprien also said that maybe they could identify among those women some of them who are more competent in self-injection, doing kind of peer education, something like that.
Yes, we have room for two questions.
Thank you so much. I will ask one question in French and English, just to facilitate the comprehension. Thank you, Dr. Cyprien, for your presentation. My question is that in DRC, I know that we have now the politic protocol regarding the woman access for the safe abortion with the Minister of Health. I don't know what is the link with this policy and your studies. And another question is that if in DRC we have the policy for the national self-care, pour reprendre en français, c'est pour voir quel est le lien entre, je sais qu'en RDC avec le PNSR, il y a un document qu'on avait supporté pour l'élaboration de documents de politique, normes et protocoles en matière de soins après avortement. Quel est le lien entre votre étude et cette politique? Et également, est-ce qu'il y a une politique nationale en matière d'auto-soins au niveau de la RDC? Voilà. Donc, c'était un peu les questions que j'avais. Maintenant, from Blamy, I just want to, the study is very interesting. The result of the study is very interesting. For me, we need to think how we can continue to invest more and how we can share better the result of this study. This will be very important to increase women access for the GMP-SC. That is just commentary. Thanks for this good study.
Okay. Merci pour la question. Oui, évidemment, en RDC, il existe ces documents-là sur les...
Yes, those documents on post-abortion care exist, and they were created with directive at all health systems level. But when abortion care are safe, when it is there's a self-abortion, when there is a complication, these women can come back to the health centers to have a follow-up. So there is a linkage between our study as part of a referral in case of complications. Now, on the self-care policy, I think there's no such thing yet in DRC, but in terms of safe abortion, with the promotion of the Maputo Protocol in the countries, we have been able to really focus on risk reduction, and that really paved the way for self-managed abortion by the women themselves on using misoprostol, whether it is in the structure or the pharmacists with whom we have been able to work in the study.
No, it doesn't. They don't exist in DRC. Regarding self-care for abortion, there are guidelines on post-abortion care. But they took advantage of the adoption of the Maputo Protocol by the Minister of Health in DRC to try to introduce, self-care for abortion. So when a woman receives misoprostol for self-care for abortion, if there is a complication, she refers to a facility now for post-abortion care.
Do we have one last question?
Yes, sorry. Okay, sorry. My question is just for DRC. Je vais traduire après la question. In some place, I know we use misoprostol for prevention of hemorrhage, postpartum hemorrhage at community level. So I don't know if in DRC we have that kind of intervention yet, and how we manage at the community level to have the right information, because it's the same product but two kind of use. Okay. Donc, ma question, c'était de savoir est-ce que il y a en DRC, enfin RDC, l'utilisation du misoprostol au niveau communautaire pour la prévention de l'hémorragie du postpartum, et comment vous faites dans ces communautés-là alors qu'on utilise le même produit pour maintenant, on va dire, faire les soins après avortement. Merci.
Oui. Au niveau de la RDC, donc, en tout cas, l'utilisation des misoprostol au niveau de la communauté, il n'y a pas cette politique. Et d'ailleurs, même dans les structures de santé, le misoprostol est beaucoup plus utilisé au niveau secondaire, au niveau des hôpitaux. Et au niveau des centres de santé, on utilise beaucoup plus l'oxytocin pour essayer de faire la GAPTA et gérer tout ce qui est comme hémorragie. Ce qui fait qu'il n'y a pas vraiment une confusion à ce niveau. Voilà.
Thank you very much. We've come to the end of this panel. If you still have questions, please feel free to reach out to our panelists. And these presentations will be available on the conference website. Please also note there will be a survey, evaluation survey for the conference. Please do fill it out when it comes to you. Thank you very much to our presenters. Have a good evening.